Hi, my presentation is on Dupuytren's contracture, also called Viking's disease. This is a myofibroblastic progressive disease that affects the palmar and digital fascia of the hand and results in contracture deformities, commonly in the fourth and fifth digits. Outcome tools you can use include the dash and quick dash to assess function of the hand. It has an unknown etiology, but it can be linked to genetics, cigarette smoking, alcoholism, diabetes, or medications used to treat seizures. And the tissues involved are the fascia and aponeurosis of the palms or the digits. There's a higher prevalence of Dupuytren's contracture in Caucasian races, particularly those of Northern European descent. An increase in mean prevalence is noted with advancing age, although rare in children. This is more prevalent in those older than 40 years. However, it progresses faster in patients younger than 50 years. Men are 7 to 15 times more likely than women to have a clinical presentation serious enough to require surgery. The mechanism of injury is just abnormal myofibroblastic growth in the hand that produces thickening of the palmar aponeurosis. There are 3 grades. Nodules are formed, and shortening of the aponeurosis creates pits in grade 1. Grade 2 is when the lines of tension forms cords that limit extension of the affected digit. Grade 3 is, as the disease progresses, the cords then shorten and lead to a flexion contracture of the digit. Common signs and symptoms include blanching of the skin when affected finger is extended. The patient may not be able to place their palm flat on the table. Their knuckle pads over the PIP joints may be tender, and you might be able to observe pits and grooves as well as painless cords proximal to the nodules. Some activity limitations include typing, texting, or writing, gripping or releasing objects, shaking hands, washing, or grooming. And these can then lead to participation restrictions in sports, as well as daily activities in the home or the workplace, especially those interacting with children or family, in playtime, carrying children, etc. Aggravating factors include increased pressure on the palms or extension of the wrist or involved digits. Easing factors can be applying heat to the palms of the hand or gentle stretching or massage to loosen the thickened tissue. There's no specific 24-hour pattern, however, it presents with constant stiffness of the wrist and hand or fingers. Pain may or may not be present. There are no specific precautions or contraindications while performing the exam or interventions. With active movement testing, there might be limitations in extension of the affected finger due to the flexion contracture at the MCP and PIP joints. And then the same thing for passive movement testing, limited extension of the affected finger due to the flexion contracture. Advanced stages presents with greater than 30 degrees of flexion contracture. Although there is no primary contractile tissue involvement, you can assess strength through resisted testing of the hand for the intrinsic muscles, finger or wrist flexors and extensors. There might be potential decreased grip strength or dexterity. There's no specific accessory motion testing, but you may do that as well, especially if you predict any hypomobility in the joints. For neurodynamics, you can test for potential compression or symptom reproduction with ulnar or median nerves. With palpation, you can feel the nodules and or cords of the palmar fascia, especially in the fourth and fifth digits. There's no special tests for Dupuytren's contracture, but there is a Houston tabletop test, and it's positive the patient is unable to lay their palm flat on the tabletop. And you can use this to follow progression of the disorder and note the angle of contracture present. Differential diagnosis include ganglion cysts, stenosing flexor tenosynovitis, soft tissue masses, trigger finger, or other fibromatosis. For diagnostic imaging, you can use MRIs that can show subcutaneous nodules and cords that lie parallel to the flexor tendons, and ultrasound may show thickened palmar fascia and the nodules. Signs and symptoms indicating referral to physician consistent worsening nature of symptoms, increase or progression of the contracture, or severe deformity that is functionally disabling. For surgical indications, the surgery is chosen usually when the MCP joint contracture exceeds 30 degrees and the deformity becomes a functional problem then, or when the PIP joint contracture exceeds 20 degrees. Patients usually undergo a fasciotomy, or you can also have an in-office percutaneous needle aponeurotomy as an alternative to surgery. All right, thank you.